eyelid surgery, face and brow lifts, and body contouring procedures such as abdominoplasty, thigh, arms lifts. He is known for detailed liposuction using water jet technology. In his aesthetic practice, he provides minimally invasive procedures including muscle relaxant injections, filler treatment, lasers, and detailed fat transfers to the face and hands, as well as cell-based rejuvenation of the skin and body. His topic is benefits and pitfalls of plastic surgery on aging skin. And I understand he's also going to talk a little bit on stem cells. So I'm quite sure this will be relevant for almost all of us. And so without much ado, can I welcome Dr. Yap. Dr. Yap, back to you.
Hello, hi. Good afternoon. I'm just going to start first of all. Can you hear me?
Yes, we can hear you.
Okay, very good, thank you. So, are you able to see my screen? I'm moving the pointer.
Yes, we can see your opening screen, benefits and pitfalls of plastic surgery on aging skin.
Now, also to check that the laser pointer is working.
Yes, it is.
Okay, ladies and gentlemen, esteemed colleagues and attendees, good afternoon. My name is Dr. Yabokuri. I would like to thank the organizing committee for the opportunity to share some ideas about the pluses and minuses of plastic surgery on aging skin here today. So it's a pretty broad topic. Obviously, I can't cover all of plastic surgery in the time we have, but I thought I might try my best to share some interesting facets of plastic surgery with you. And let me try and see if I can get this working. So most of my patients are very concerned about privacy. In fact, most of them would not agree to show their photos here, so I would request your help by not recording any media here. We do try to anonymize as much as possible our patients to protect their privacy. And healthy aging is, of course, the central theme of this. So part of this, healthy aging, sorry, are we okay then? Can I proceed? Yes? Yes. Okay, so part of this is a desire to age gracefully, both by feeling and looking good. And just for completeness, before we start on the treatment options, I thought I might talk a little bit about plastic surgery and remind everyone what plastic surgery is, because we have some popular misconceptions. So plastic surgery is a broad surgical specialty that involves the restoration, reconstruction, or alteration of the human body, but it's not confined to a single organ system. It can be divided into two main categories, so reconstructive surgery and the more popularly known cosmetic and aesthetic surgery. The specialty is technically demanding, and it's a naturally creative field that is constantly changing and evolving itself and pushed forward by highly creative and talented individuals from many countries. We treat pathologies that range from congenital conditions to cancer, trauma, degenerative and autoimmune conditions, and frequently we work alongside other specialties, both surgical and medical, such as general surgery, gynecology, neurosurgery, orthopedic surgery, to reconstruct anomalies and defects in the body, to restore as much the appearance and function as possible. So as an example, I wanted to show this interesting patient who was injured at the Battle of Jutland in 1917. He's Walter Yeo, a sailor in the British Navy. He suffered severe burns for which he received flap surgery and skin grafts in what is considered to be the first plastic surgery operation of modern times. His surgeon, Sir Harold Gillies, is considered the father of plastic surgery, which subsequently underwent the Renaissance due to the complex reconstructions needed in the successive engagements of World War I and II. So you can see here the limited eyelid closure, retraced and tight nostril apertures, loss of the eyebrow, facial hair, and a thickened piece of skin, which was considered very advanced for the time, but perhaps less so today. And fast forward almost a century, and this is for perspective and to illustrate where we are today. What I consider the state of the art in current plastic surgery, the face, taking off the entire lower 2/3 of the face. Motor and sensory nerves. It is a staggering technical achievement for our time, and the cost as well as the manpower time involved would have been enormous and I think just simply overpowering. But this is an example of how far medicine has come, but also a testimony to the amazing rate of change and acceleration of learning in this very exciting time that we live in. But let's come back to aging. So why are we talking about aging? Well, it's a significant problem. The United States Census Bureau estimates that the population of the population of United States that is greater than 65 years old, these individuals will number more than 88 million by 2050 compared to 2015. This is a 105% increase. And here are some of the processes contributing to aging. These are processes that I think many of you are familiar with. Dr. Lopez-Orton listed some of these in an article, very nice article in Cell. And these so-called hallmarks of aging include genomic instability, telomere attrition, loss of proteostasis, deregulated nutrient sensing, stem cell exhaustion, and also cellular senescence. Now, cellular senescence is a major process that imposes a permanent stop to cellular growth in response to various stresses. First suggested by Hayflick and Moorhead that senescence and aging might be linked. We know now that primary human cells have a limited number of divisions, known as the Hayflick limit, about 50, and senescence reduces tissue repair capacity while damaged cells produce pro-inflammatory and matrix-degrading molecules in the so-called senescence-associated secretory phenotype SASP. This stems from the dissociation of transcription factor GATA4 and the autophagic adapter P62, very important pathway, which increases inflammatory response and drives aging. But what happens in normal aging is that we have a combination of all of these processes giving rise to epigenetic stress, proteotoxic stresses, oxidative stresses, and telomeric attrition in association with DNA damage. Now, this is a process that occurs normally in age-related tissue deterioration. When you add in a disease, let's say smoking, for example, causing COPD, wear and tear damage, this also increases the rate and the extent of telomere damage and DNA damage. This can also happen in therapy situations. So, for example, chemotherapy. We know that chemotherapy itself can cause accelerated aging throughout the whole body based on telomere erosions and DNA damage in non-cancer, non-target cells. But they can also occur in solitary organs, such as after a kidney transplant. Again, proteotoxic stress, oxidative stress, telomere damage, and DNA damage. Add all of this together, we have a high organ-specific or body-specific pre-senescent stress with a compromised immune system causing accelerated aging, and in the case of transplants, increased risk of transplant failure or organ dysfunction. If we consider anatomical aspects of change, this can happen in all the tissues: skin, fatty tissue, bone, muscle, blood vessels, and connective tissues. So frailty in patients can affect outcomes in plastic surgery. So for example, important changes in the skin can occur due to loss of tissue volume and skin thickness. So as we age, the skin loses volume and thickness. There is decreased cross-linking of elastin and collagen, thinning of the upper layers of skin, and our patients call these conditions wrinkles, and they are very bothered by this. Now, fibroblasts are reduced in number and activity. This shows slower production of collagen and elastin, as well as the skin matrices of glycols, aminoglycans, resulting in thinner and less elastic skin. This is associated with a reduction in cutaneous blood flow and a reduction in new collagenesis, meaning that wound healing, regeneration are reduced because of a reduced cell turnover, and this all feeds back to create problems when we carry out operations. You can see that the collagen becomes disorganized and the skin can become hyperpigmented due to a lifetime of exposure. Plus progenitor cells with an increased risk of fracture. Further, disorders of metabolism and nutrition can disrupt and delay healing. We also see this in fat cells. Regeneration and synthesis are reduced, along with reduced insulin sensitivity. Cellular senescence develops and fat distribution changes to favor ectopic deposition, as well as an increase in visceral fat. Similar changes can occur in muscle, nerve, and tendons. For example, muscle reduces its mass by about 30% with aging, whereas nerves can show demyelination, synapse number reduction, a decline in nerve conduction velocity. Following injury, nerve regeneration and tissue regeneration is also delayed and less effective. So, in summary, general risk management is important in plastic surgery, particularly as some complex reconstructions can take much longer than standard procedures. These are long procedures such as microvascular tissue transfers, nerve reconstructions, and facial and ear reconstructions. Patients therefore need to be able, in such situations, to tolerate the lying position with prolonged immobility. There is a risk of bed sores, pressure sores, and DVT, and a significant number of these operations are elective, and some of them are for appearance only. Therefore, a no-risk tolerance approach is applied. And we need to consider problems, potential problems, and underlying conditions in all of the major systems. So in the cardiovascular system, a preoperative assessment as for general surgical patients for risks of hypertension, stroke, MI, PE, and DVT. For example, in the endocrine system, glucose control, thyroid hormone levels, cortisol, and other regulatory levels of steroid hormones, kidney function, nutrition, strength, and the potential for wound healing, recovery, and tissue healing. I'm going to move on now to show some of the changes in the face associated with aging. From the left, these images represent in series an average appearance of a 20-year-old, a 50-year-old, and a 75-year-old. So in the youthful face, there is a balanced distribution of superficial and deep fat, giving rise to a smooth three-dimensional contour map that we see as a series of arcs and convexities. On the frontal view, this is outlined by the temporal foreheads and also the lip contours. Our eyes follow the anterior visible jawline, more angular in men and more curved and narrow in women. The lateral view, which I will show you on the next page, is associated with forehead contour, the oblique OG or lateral cheek, and the extension of the jawline from the mandibular angle to the chin. In the aged face, loss of facial volume will cause muscle and skeletal structures to become more evident. Thinning and loss of volume in the mid-face gives an appearance of descent. Involutional exposure of fat deposits in the jowl and chin will also worsen the appearance of descent. Particularly in the lower third, we can see loss of cheek and parietal fat, loss of the maxillary and mandibular bony resorption, weakened ligamentous support. The platysma can pull downwards, showing vertical platysmal bands, and in association with loss of tissue elasticity and the increase in lower facial fat can cause a turkey neck deformity. Protrusion of the submental fat can occur beyond the level of the platysmal muscle and therefore give rise to worsening of the visibility of the vertical platysmal glands as well as the neck wrinkles. In severe situations, the higher bone and iris complex can descend and further add to the loss of the cervicomental angle, creating an impression of a thick neck with no definition. I was very surprised and happy to see some of my work done for me in these Photoshop series where celebrities have been put together with their younger and older selves. And this is quite useful to see them as they were younger. So, you know, with fuller cheeks, no creases almost, and a flawless complexion, compared to the aged look as we discussed. Jowl development, coarse wrinkles, fine wrinkles, deep neck wrinkles, deep neck folds, palpebral wrinkles, dyschromias, and loss of the fine texture. And it's useful to look at these pictures because this is what happens in aging, but this is, from this direction, the left to the right, is where we want to go if we want to improve and have a nice aesthetic outcome from the processes that we want to create for the patient. Further changes can affect the skeleton, and here we see the aging process in a bit more detail, highlighting the tendency for the upper, inner, and lower outer aspects of the orbit as prone to bony resorptive processes in aging. With age, the larger arrows on the right show the relative amount of absorption in the facial skeleton, particularly in the piriform area and the maxillary areas. And so with age, these bony areas become less prominent and provide less support to the soft tissues, and again, will highlight areas where visible folds and contour defects can appear, as illustrated here, with deepened nasolabial furrows, asymmetric descent of brows, a very much deepening of an already deep infraorbital sulcus, lateral skin decreasing, thinning of the lips, widening of the chin, development of the jowl, and platysma bands. A lateral view showing again the maxillary retrusion with age, again giving rise to lack of support centrally, so that the nasal base and the upper part and lower parts of the maxilla are retruded. This has an impact on the visibility of the palpebral skin creases, the palpebral cheek junction, the nasojugal fold, tear trough, as well as the lateral cheek and the labiomandibular creases. You can see some of the changes again summarized here. Deep brow lines, descent of the brow, deepening of the periorbital creases, descent of the middle fat pad, prominent jowls, again, dyschromis. But just to note that smoking is particularly dangerous in plastic surgery patients due to the combination of the nicotinic acid vasoconstriction as well as irreversible oxyhemoglobin binding by carbon monoxide, to name but a few. Of course, you can see a graduated change from young to old with progressive worsening and deepening of sulcus, descent of tissues, and progressive visibility of creases summarized here. But of course, there are also some celebrities which we all envy who appear to be quite immune to the effects of aging, at least at an earlier age. Some people do age better than others. So what are the specific risks of plastic surgery? Well, putting aside the general risks of surgery in the older patient, the specific risks of plastic surgery depend on the type of patient, the aesthetic goals, the procedure, and the operative site. Particular to our specialty in the cosmetic sector is a relentless drive for perfection. So I wanted to go through some of the procedure-specific risks of this specialty. And there is a continuing drive to be perfect. This is the case of a famous patient in China, and I think reflects an increasing trend in Asia. The cosmetic market in China alone is worth 14 billion US dollars, and it's now the second largest market for cosmetic surgery in the world. 15 to 20 million patients annually in China get this type of procedure, but only 12% of beauty clinics are licensed and compliant with regulations, and this has implications and also echoes our current situation here in Malaysia. There are high standards for highest possible cosmetic outcomes for business and for online presence. So I think this unfortunate situation is likely to continue. And already a nice nose with a said to be cartilage graft in the tip of the nose, but I suspect probably due to previous treatment as well, had reduced blood supply in, and therefore an unfortunate complication resulting in loss of the nasal skin occurred, which is quite noticeable and quite important in this area. One of the more dangerous operations is the Brazilian butt lift. So here you see a former beauty queen who had several episodes of illegal injections causing inflammation, edema, repeated infections, and scarring. In these kind of cases, it's almost impossible to separate out the planes between normal tissue and inflamed tissue. The inflammation just makes an already large area larger. This lady's buttocks measured 60 inches already. And as you can see, it is very disproportionate to the rest of her body. Here you see a further person who had problems with injections. Large is very popular in Miami, and several years ago there were runs of patients, 30 to 40 mortalities within a period of 2 to 3 years due to deep injection of either fat or filler material. So when you're doing this procedure, if the cannula enters the deep gluteal veins, a pulmonary embolus can occur very quickly. In this kind of situation, there's nothing you can do, and the patient dies within 10 seconds. So it's something that we really, really want to avoid. When I'm doing procedures like this, I confine myself to doing superficial fat grafting only. I stay very, very well away from the deep tissues to avoid complications. And while we're on the topic of injectable fillers, just wanted to highlight the case of a Korean model, Han Myo-koo, who's very well known. She started off being very beautiful and then persisted in injecting non-medical grade silicone along with the filler craze. And as you can see, she then sustained irrecoverable, irretrievable chronic lymphedema with infections. This is not the only complication, and there are quite a few complications that we see. So irrespective of age, since this topic is about age of patient, I think it's important to take care about what you put in your face, and this needs to be really, really discussed very well with your aesthetic treatment person. Unfortunately, these do not come to the attention of the public as much as the beautiful outcomes due to marketing efforts. So I also see many patients who have too much filler in their face, resulting in a very disordered or strange appearance. And you will see me talking about this in all of the slides. So a disordered or strange appearance is very much a complication of all of these things. Fillers are very popular in Malaysia with many operators and beauty centers, some of them unlicensed, offering such services. We are focusing on the facelift and eyelid surgery today, so I will consider them together. Facelift and neck lift can be a long procedure in my hands. However, surprisingly, they do not cause much pain. But the patients do need to be fit enough for a long procedure in case of unexpected findings. So for all my patients, especially the older ones, I do have a strict policy on making sure that they are healthy before surgery. Thankfully, I've never had an on-table incident. Nobody's died in my hands, hopefully never will, but there's always a risk. And these risks include coma, deep vein thrombosis, cardiovascular events, pulmonary events, and significantly facial nerve damage. Nothing is worth a facial nerve damage and paralysis in the patients, as I will show you later on. So this is to be avoided at all costs. However, in most situations, I think we're quite lucky that these will actually recover. I've not had one yet. I hope I never have one. Facelift can also be complicated by extreme artificial and unbalanced appearances. And if you move on from the face, the eyelid surgery, periorbital region is also a very important part for aesthetic changes. I have never seen anyone with blindness due to this surgery, although this is commonly listed upon the problems. The satisfaction is quite high because it's almost impossible to get absolute symmetry, and along with all cosmetic procedures, it is highly subject to the aesthetic expectations of the patient. So I'm going to show you both combined. So Grishka and Igor Bogdanov were Russian-French twins, allegedly with a royal background. They were obsessed about plastic surgery and recently deceased just a few months ago from COVID. Sorry to hear. But they were controversial and colorful figures. At an initial glance, they seem to tick all the boxes. So there's elevated cheeks, elevated brows, and good chin projection. However, these are good examples of symmetric ratios carried out to extremes, and they look to normal eyes pretty abnormal. When you take this to further extremes, this is Rodrigo Alves, who is also known as the Ken doll man. He tried to make himself into a Ken doll and subsequently had a transgender procedure. Ostensibly, this is you can see a smooth brow, high cheekbones, a balanced gaze, and correct proportions of the upper lip and the lower lip, and a clean jawline. But it's all quite artificial. She shows much less excursion of the upper lip and more filling of the lateral nose area. Again, a hugely disproportionate buttock area and now a feminist jawline, which still looks artificial. And of course, we talked about this, the buttock enlargement. But plastic surgery addiction is real. We can consider the multiple factors that sometimes lead to an unhealthy obsession with cosmetic plastic surgery. This lady, Jennifer Pamplona, spent $550,000 US over 30 operations in Turkey and nearly died after 3 weeks of fat injections in her buttocks. I think this is entirely unnecessary because she was already a very good-looking Versace model before all of her operations. There are issues such as psychological dissatisfaction, depression, self-loathing, lack of confidence, and very importantly, a significantly higher percentage of plastic surgery patients than normal have this thing called body dysmorphic disorder, where they think they look, fat, skinny, or unbeautiful, or too fat, or too skinny, in spite of a normal appreciation of aesthetic values showing the contrary. This kind of treatment process certainly calls into question value systems for both the patient and their treating physician, and there's always, I suspect, an underlying profit motive. Anyway, back in the normal surgery world, when we consider facial rejuvenation as a treatment for aging, we want to look at all these factors to formulate a plan. So the anatomy, skin versus a superficial musculoaponeurotic system procedure, the quality of the skin, texture, vascularity, elasticity, and thickness, and also ligamentous support, plus an assessment of the volume of the tissue with sagginess extent. I'm going to just very quickly list these for you. There are many methods of treatment for skin texture, some of which give very, very nice results, such as surface conditioners, microneedling, cell-based therapies, energy-based treatments, such as radiofrequency, ultrasound, lasers. And for volume, we have injectables as we have already seen. We can use multi-threading and fat grafts, but carefully. So for sagging and visible effects of gravity, we can start with energy-based treatments for the more minor cases, thread suspension, and volumizing treatments, and progressive to surgical skin tightening. So I would now like to give you a short overview of facelift surgery as an example of skin tightening or lifting procedures. And the primary indication of facelift is a significant excess of skin associated with descent of male fat pads, smash laxity and facial drooping, ligamentous laxity, and what we call facial aging not otherwise correctable. There are quite a few options. I won't go through all of these, except that you can go in increasing complexity from skin only to a composite deep plane facelift. And these vary based on the extent of skin undermining, the extent of mass undermining, the direction of pull, and the presence of secondary procedures. So this is an example outlining the basic concept of what we would call the foundation for most facelift procedures. The incision goes from the temple, sometimes varying in distance to the front of the tragus, around the front of the tragus or right at the tragus, to go below the earlobe and to extend a little bit into the hairline or along the mastoid skin. The skin is elevated, and a dissection is carried out into the deeper layer. The aim is to try and get past the SMARS layer into and beyond the nasolabial fold to detach attachments from the skin and superficial tissues, which tether the skin and soft tissues to the underlying deeper structures and bone. And in doing so, this helps us to release the tethering and the anchors to allow upward while protecting other nerves like the mandibular branch and the temporal frontal branch of the facial nerve. We try to go in front of the zygomaticus muscle complex so that these nerves are protected and not at risk. And the overall vectors are usually vertical when you look at it more anteriorly and more lateral or horizontal posteriorly. In addition, a platysmoplasty is shown here pulling the muscle tissues forward, suspending like a hammock backwards in the neck. So there are variations to this schema, and anteriorly it's very important to preserve the sideburn hair, which if you remove the sideburn hair, the loose skin can look somewhat odd. The benefits of a facelift are fast elevation and suspension of tissues. It's relatively pain-free, and there is a superior extent of change and differential control of suspension vectors, so you can pull up a little bit further back or a little bit back, depending on what the patient needs, and it can be combined with other procedures. But the disadvantages are that it's technically demanding, time-consuming, with a slightly longer recovery time compared to some of the more minor procedures. There are significant risks if it's not correctly done. Nerve damage can be permanent, and you can have conditions like seroma, stellarial fistula, and asymmetry. Aesthetic dissatisfaction, as with everything else, is always a real possibility, and skin necrosis, particular risks with patients who have previous treatments, previous fillers, previous threads, and patients with history of smoking. So this is an illustration from the anatomy of one of my patients who, not a facelift, but it illustrates the anatomy very well, who had recurrent parotid, as you see, requiring a total parotid resection, including the anterior part and, the superficial lobe and deeper lobe. I show these photos because they illustrate clearly the thinness of tissue and the various myopathies of nerves and vessels. So this is the internal jugular vein. The superficial and deep lobes of the parotid gland and the submandibular gland have been removed. You can see the hypoglossal nerve picking across the digastric. The accessory nerve, the lymph nerve, the facial nerve with its temporal, the buccal branches, and the mandibular branch are well illustrated here. These are branches of the cervical plexus, some of them coming forward around the internal jugular vein. And this is the carotid artery. Lying in here is the vagus nerve, and deep to this is the phrenic nerve. So these are the structures that we worry about the facelift surgery, although we are normally not so deep. But the other point about this is that this patient illustrates the extent to which facial skin can be elevated and still be well vascularized, enabling us to carry out wide subcutaneous dissections, although there can be exceptions. So this is one of my patients with facelift dissection and elevation of the SMARS layer. So this is a thin elevation of the skin and elevation of the superficial musculo-aponeurotic system for traction. It's a firm fibrotic area, and here we are just testing out the differential directions of pull. And you can see here again, a fairly thick SMARS layer. This is the parotidal-mesenteric fascia just underneath it, and with underlying that are the nerves, the facial nerves, which we try to avoid injuring. And I think this is a patient with a revision procedure, so you can see some of the scar adhesions and also some of the fibrovascular pedicles, but stitches from previous repair. And in this situation, this mask layer becomes a little bit more tenuous. However, you can still get a pretty good layer. So this is verging upon a deep SMARS, deep combined procedure. I'm going to try and show you a video here. Let's see if this works. So this is a dissection showing anchoring of the stitches of this mask layer, and you can put it to the preauricular deep fascia, which is tight, and so these areas compromise the areas of the non-mobile mask, which provide a stable anchoring platform for stitches to be tightened. You can see the results here. A slightly wider cheek, slightly wider angle of mouth with a tightening, and a sharper definition. This patient also had a revision lower eyelid surgery and stage brow. But neck tightening is also something that we can do at the same time. And this is done using a subchin incision. We tighten both posterior and anterior. So it goes backwards and forwards, and a division of muscle if necessary. It's helpful for a smooth neck appearance. And so this is direct access into the front of the neck, showing the platysma muscle fibers on either side and mobilizing them for the anchoring so that we bring the front edges of the platysmas together so that we can actually bring them and tighten them. So these are results to show the neck part of the facelift and neck lift. And you can see in this patient, sorry for the anonymization here. So you can see that there's an improvement in the contour, reduced in the deep neck wrinkles, and improved contour, both, plus also a narrowing of the chin area and a smoothening of the contours overall. Similar changes, lots of deep wrinkles, lots of creases here, all improved within a couple of weeks after the face and neck lift. We can also address the brow and forehead area, and this can be done either open or with endoscopic instruments, as is more usually the case. I prefer to do this type of thing through endoscopic incisions. The mid-face can similarly be treated in isolation as a smaller procedure, so you can put the tracking through the temporal area and lift the Bichat's pad here, and also the Sooth fat pad here. In considering facial rejuvenation, we are also looking at the eye region, which has a big impact on facial aesthetics. Many patients are concerned with bulging above and retraction at the level of the orbitomalar and tear trough ligaments, as well as the zygomatic cutaneous ligaments, which restrict movement and hence bulging and need to be addressed in consideration of facial surgical treatment. So these are the defects. They are tightly adherent to the bone. The fat bulges out because this tissue is thinned but also weakened. There's less tone in the muscle, and so this produces our classic eye back appearance. There is a lot of complicated anatomy in this region. We are usually working around the pre-zygomatic space, and this is not just for surgery, but also a target area for fat filling or filler injections. Caution is required in this and other to a multiplicity of vessels, which provide thrombosis of the central retinal artery, resulting in blindness. So there's a vessel here, the branch of the angular branch here of the facial artery, which can be injured easily. And more on the fillers, this lady had a bad experience with fillers to the inferior orbital rim, one of my patients, with several palpable nodules, 6 times 8 millimeters by several, which bothered her and did not dissolve either with time. She waited for 2 years, or hyaluronidase injections. She had several treatments in 3 different clinics. After some discussion, it was decided to do open removal through a subciliary incision. And so here she is 1 week post-op with a little bit more bruising than normal because I had to do quite a lot of dissecting above and below the muscle in order to clear the area of all the nodular filler collections. But 1 month post-op, she seems pretty good. And it's an interesting use of the lower eyelid blepharoplasty approach. You can see that this is before and after, a lot of swelling here, which they don't like, and a much better, much more normal contour with less swelling after the surgery on animation. Another patient with asymmetric upper eyelid and multiple creases with a minor small droop of about 1.5 millimeters. So this was corrected with a simultaneous tightening of the levator, aponeurosis to improve the mild ptosis, and with a reasonable scar, with the results still maintained after 3 years and fairly symmetrical. This is a young girl undergoing short scar incision Here's 5 days after surgery with no pre-existing crease. And so this is one of the most popular procedures that are requested in Asian patients. And so she had a clear crease created. If you look carefully, there is just a very mild degree of asymmetry, even though the distance from the ciliary edge to the incision is carefully measured multiple times. This type of surgery is also very attractive for men. And so this is a gentleman with bulgy lower eye bags and dropped upper eyelid. He underwent bilateral upper and lower eyelid surgery with nervated tightening. Fat was reduced from the lower eyelid area, and so the bulge is quite in keeping with fashion, I think, at the moment. People like to have a little bit of prominence here because this gives a youthful appearance to the lower eyelid area. But I think this patient is one of the most complicated in this series. Another patient with actually a very nice pre-existing appearance wanted a very subtle, very normal correction of the crease, just a little bit of raise of the crease. This turned out to be quite difficult for me to do to achieve symmetry. I had to readjust this another time in order to correct a 0.5 millimeter difference at the patient's request. And she also had a simultaneous echocantoplasty, and this developed as sometimes it's the case, prominent scars. So I had to do a scar revision with some steroid injections. But after 5.5 months, we finally came up with the result that she's fairly happy with. But these are all younger patients. And so if you operate in younger patients, they do tend to have slightly better outcomes than older patients because of skin turgor, skin elasticity, and also just general health of the tissue tension. So just a very, very mild and subtle correction here. And some of you may query whether or not this is worth it, but patients generally are very keen to have this type of procedure. So I'd like to switch topics and move to an exciting new area for facial rejuvenation. This slide shows the basic structure of facial skin with superficial fat, this mask layer. Unfiltered fat injected in scarred and injured areas gives rise to very good healing, shown here in a series of burn children from Pakistan, with improvement in pigmentation, thickness of scar tissue, and rigidity, significant improvement after 6 months, just unfiltered standard fat grafts. And so we have been using this. When I first started training, I remember seeing my teachers doing extremely tight facelifts in thinner older women, but the results were always just looking like thinner older women with extremely tight facelifts. With fat grafts now, we have an opportunity, as in this lady, to approach what they looked like when they were younger, simply by restoring the volume, but also by a very strong regenerative approach with the fat. And you can see in this lady undergoing fat facelifts that she looks like at the age of 55 after a facelift, what she looked like, nearly similar to what she was about 30 years previously, except that there's a little bit of a deeper sulcus here, and if we were doing it now, probably would add in a little bit of fat there. And this is also extending to our lower eyelids, and so there is an option for us now to undergo less aggressive lower eyelid surgery and instead just remove some fat, removing a bit of the skin and layering this with fat. So this is a patient who is undergoing filling of the right cheek tear trough, and this is under local. You can see that she already has had a small blepharoplasty done, and the cannula is just underneath the skin and just above to the muscle in this area. And you can see the little clickings of the injector delivering, in this case, about 0.04 cc's per click, so that we are minimizing irregularities and also maximizing survival of the fat grafts. Here's one of our patients who underwent exactly this, upper and lower eyelid surgery, neck and facelift, fat grafting the cheeks, infraorbital rims, chin, jawline, and fat stem cell injections to the face. So as you might expect, he has a lot of bruising areas, but he is very happy. And this was an initial swollen appearance within the first week. So he looks like he's just been hit by a bus because of all the bruising. But here he is a few weeks later, and you can see that with the fat and the skin excision and careful anatomic planning, he looks very, very young. He's extremely happy with his results 3 years on, and he tells everyone he feels like a 28-year-old. So I'm pretty happy with that. Facelifts are the gold standard for facial suspension, rhytidectomy, structural soft tissue rejuvenation. It's the longest lasting results we have. Experience and technical skill and anatomical knowledge are required, but it's challenging and rewarding. In comparison with other suspension technologies, the results are easier to appreciate in facelifts. They're apparent earlier, they last a bit longer, but correspondingly initial costs are higher. recovery times are a bit longer and the risks are higher. So I think it's important to have a combined approach, patient-directed approach, and consider all of these sites. Medical fitness and correction targets are specific and very important in the older age group. We treat areas of concern. Each treatment modality is best at one aspect of policy correction. And therefore, since no treatment modality is the best at everything, we have a palette that we can select different treatments from so that we can correct more and we can achieve better satisfaction. I think there's some important points that there is no perfect facelift. There is no perfect age for surgery, although I will say that in patients who are having the operation in their mid to early 50s, they seem to last longest. Patients who come for facelift when they are in their late 60s to early 70s, older skin does have a risk of earlier, faster recurrence, and therefore results are less optimal in older patients. So one of the concerns that we have in older patients is that we must make sure that their outcomes can meet their expectations, and it's always, regardless whether it's an eye surgery or breast surgery or abdominal surgery or facelift surgery, results are usually less optimal in older patients because of the factors that we've discussed earlier, the general health, associated conditions, associated diseases, the condition of their skin, sun damage, and conditions such as endocrine and cardiovascular problems. Operative risks can therefore be significant, although in recent reviews, the main operation that had a significant contributor of age as a factor for morbidity. So we talked about this already. The benefits are that there are techniques such as surgical techniques, anesthetic techniques, and post-operative support techniques that can nowadays provide better results than we were able to achieve previously. So most patients have very little pain and very discomfort, and advances in technology allow us to do minimally invasive surgery with better outcomes and faster recovery. There is an improved mental health and improved quality of life. And I think at this point, we want to ask, is 65 the new 45? So I think this is best exemplified by Prof. Nathan, with a very good paragon of fitness and health. And I think we should all look at this: calorie restriction, mimetics of calorie restriction, reducing a high protein diet, and maybe considering the role of metformin and rapamycin, and of course, good diet and exercise. So I want to summarize here. I think I'm quite up to time now. Plastic surgery, to answer the question posted at the beginning of this talk, can help improve quality of life. It does require a detailed analysis and a comprehensive approach with a bespoke plan for rejuvenation. We can use multiple modalities. I'm going to stop here and say thank you. If we have time, I might show you a few more slides, a couple of videos on stem cell therapies, additional therapies, and fat grafting in relation to adipose-derived autologous stem cells for patients. So thank you very much, and back to you, Dr. Das.
Is there any questions from the floor, or shall we allow him to proceed with just a few slides on stem cells? Are you all happy with that? The audience seems quite happy to allow you to proceed with the next few slides.
Good, thank you very much for that. So I think this is a very exciting thing, but when we talk about fat harvesting for fat grafts, we always think, well, is this safe, is it painful, and will there be complications? Well, this probably belongs in a liposuction lecture, but anyway, I just wanted to show you this. This is somebody with a proper liposuction. So you can see this is a water jet procedure under GA. The patient has a fairly significant thickening of fat in the medial thigh area, which is more obvious after we put in the tumescent solution. And here I'm using an excess incision in the middle aspect of the geniculate area. The procedure is pretty well tolerated, and so far I have no patients with hematomas, vessel, or organ injury, but only 2 secondary reshaping procedures in the last 20 years. And some patients are not keen to have general anesthetic, so it's actually possible to have this fully awake under local anesthetic. You can see a patient having a conversation here. But of course, this needs to be done carefully in the correct patient, and you have to take extra care not to create accidental visceral injuries. And where do we put the fat? Well, the fat allows us to, because it's biological, it's also your own tissue. It allows us to contour and volumize many different areas. So I'm going to sneakily put in some pictures of breast. So this is a lady who is 48 months post fat grafting with well-retained shape and 300 cc each side. So very anatomic and a good alternative to implants. And another lady with 194 cc of each side. And someone who actually liked it but wanted more volume. So we added in 200 cc implants, and this can give quite a nice result as well, because there is some resorption with the fat over time. But one of the myths about fat grafting is that it disappears over time, and actually anything that survives over 3 months is permanent. So, and just to compare it, this is a patient with implants, and you can see very similar outcomes with implants. So it's difficult to tell the difference between them. Sometimes, especially with older patients, you get a bit of droop. So again, going with the concept and principle of skin tightening and volume, sometimes not just volume, but removal of extra skin and suspension is required. So this is kind of like the facelift for the breast. Now, mechanisms of rejuvenation are very interesting. Why do we get such nice results with fat graft and adipose-derived skin stem cells? These images are pre-treatment of, on the left, stem cells. Upper row with the Austin stain, you can see an increase in the black elastic fibers in the superficial dermis area. And in the bottom row with the H&E stain, the number of blood cells and capillary network is improved at the junctional area. So a follow-up study 5 years later showed a new production and regeneration of neuronin, oxytocin, and elastin fiber network within the papillary dermis, as well as simultaneous removal of unwanted elastosis. And this is quite significant because it allows us now to repair pretty much the whole thickness of the skin. So this is a cross-sectional area, upper layer, deeper layer showing the fat cells, and you can see untreated showing disorganized blood vessels. The treated areas show a better organization and finer blood vessels here, but a better organization and thinner collagen fibrils in both the stem cell injected tissues and also the fat injection tissues. So the fat cells with SVF had equivalent results in rejuvenation as the stem cells. And this is not surprising because I'll show you a slide that shows that there are lots of regenerative cells in fat. So putting it all together, we have facial beauty, we can talk about texture, and these are the things that we can do: laser PRP, stem cell vitamin injections. Pore size can be managed with dermabrasion, CO2 lasers, acid fields, and energy resurfacing. And brightness, vitamin injections, topical treatments, topical medications, volume with fillers, fat grafts, and some types of resuspension surgery as we discussed, and of course the suspensions, we just talked about it. But here are a set of results from Dr. Cohen, who is very impressive, I think. This lady is unbelievably 70-year-old. She has superficial fat and deep fat loss of cheek contours, bad wrinkling. Here she is 6 months post-operatively after being treated with a high-mass facelift, platysmoplasty, upper and lower blepharoplasty, and some fat grafting in different sizes to the upper eyelid sulcus, the lower eyelid sulcus, and basically recontouring the entire face. A similar lady, 67 years old, 6 months after treatment with a similar regimen. So you can see here that the red is the deep fat replacement, orange is the fat replacement for bone deficiency, as we highlighted earlier on, and the blue is a microfat for replacement of superficial fat. So again, Dr. Cohen's work very impressive. 6 months after treatment, showing the restoration of volume with very interesting improvement in the skin quality, the skin texture, the color, and so on. There are very, very many options nowadays, and it's become very popular because of the relative fast speed of this superficial skin conditioning treatments. So here is a patient that is undergoing machine-assisted multiple guided PRP injections. So we do about 3,000 injections in the face, and you can see the injector going, it actually sucks up the skin. And then there is a multiple injector which injects PRP solution concentrate, platelet-rich plasma concentrate at a predefined depth. And we have found this to promote tissue healing and promote regeneration up to a period of about 6 months, for which patients are usually pretty happy. The recovery is pretty fast, and it can be carried out under local anesthesia. Here's a different type of injector, and this is vitamins, and we can also use fat-based solutions for this. Recently, we have been trying this with exosomes, and also getting quite nice results. Micronized fat can be used to regenerate the hair follicles. Over 6 months, studies have shown an increase in density and thickness by about 30%. So I use a different injector for this. You need to inject this in deep rows. And there is a side table demonstration of how we break down the components and then filter it. There's a lot of pushing and pulling, but essentially we're trying to basically reduce the normal architecture of the fat. Now, when we talk about stem cells, there are embryonal derived stem cells, there are induced pluripotential stem cells, and somatic stem cells. The big risk that we talked about and we're worried about is teratomal risk. There are sometimes ethical issues with embryonal stem cells because of the potential for harvest from unwanted pregnancies. But certainly with somatic stem cells, autologous stem cells, there's no such risk. Stem cells can be taken up from these various sources, which I'm sure all of you are quite familiar with. There is a considered higher therapeutic potential with adipose tissue stem cells, which seems to fall naturally to us because we like doing a lot of liposuction. Stem cells have been shown to have positive effects on almost every human anatomic system. And as you have seen previously, once the fat is harvested, we can carry out direct enzymatic concentration of the stromal vascular fraction or stem cells. Alternatively, these can be taken for clonal expansion. When you inject it into the body, for the first 2 to 3 days, they end up in the fine pulmonary capillary network, following which they then go to the hematopoietic system to congregate in spleen and liver. Within 5 to 7 days, they're able to travel to sites of inflammation and injury due to the action of chemical messengers. Here is the summary of the process. We do liposuction, we centrifuge it out. This can be then broken down by enzymatic dissection, and through a process of concentration and filtration, we are left with a substance or a concentrated collection of progenitor cells and stem cells. And there are a lot of cells available in this stromal vascular fraction, such as adipose-derived stromal cells, growth factors, endothelial cells, endothelial progenitor cells, and a whole bunch of different growth factors. And it's interesting that in fat, although the fat cell is the largest, 80% by number of the cells are actually stromal stem cells, ADSCs, and other precursor cells rather than fat cells. Fat cells by number only account for about 20%. So you can use it to increase hair growth, very interesting. And you can also use micronized fat to actually regenerate these areas of fine skin. Here shown 7 hours after fat redraping, blepharoplasty, and intradermal injection of nanofat. And a very early 1 month resolution of hyperpigmentation in the lower eyelid area, improvement in the chest skin wrinkles. And however, there are certain risk factors, including cellular rejection, disease transmission, and there's always a potential, especially if external stem cells are used, stem cells from another individual, there's a risk of engraftment at an unwanted location, neoplasm formation. So these are the things we do worry about. But I wanted to show you, this is a report from 2019 in the Mayo Clinic, where there was the first kind of formal report of a use of autologous adipose tissue-derived mesenchymal stem cells in the treatment of paralysis due to traumatic spinal cord injury.
Exclusive. If you're at home, please stop what you're doing. You're going to want to see this. A man paralyzed from the neck down.
I think it's frozen. Yeah.
Mayo Clinic in Minnesota is publishing the results of a stem cell trial. The first patient in the trial is Chris Barr, paralyzed from the neck down nearly 3.
Okay, so it's going to take a bit long. I'm sorry. I just wanted to cut that short because it just basically shows a very good result from the stem cell. I'm afraid I can't actually get the control up. I wanted to skip that for you, but I think time is moving on. But basically, that video shows that there was a very good response from the injection of the stem cell intrathecally, and I couldn't actually get the controls working. Anyway, I wanted to finish by saying that healthy aging. Let me just finish with this slide. Anyway, I just want to say thank you to all of you for attending the lecture and the times can pop. But if I can, I'll try and dig out that video with control for you. Thank you very much. I want to finish by saying that plastic surgery can be quite successful and beneficial in terms of confidence and mental health for patients. And so it's something that we should consider, not consider, but it needs a very careful bespoke plan and the consideration of all the associated risks and careful management of the elderly patient. Thank you very much for your consideration.
Shall we give him a big clap? Thank you very much, you all, for being such a wonderful audience and staying patiently right to the end. And thank you, Dr. Yap, for such a comprehensive talk. I don't think we can allow any more questions for the sake of time, but if you really want to, probably I think Dr. Yap wouldn't mind you contacting him directly through maybe Prince Scott if you have any burning issues. Would that be all right, Dr. Yap?
Sure, absolutely. Yeah, no problem.
So thank you, everybody, and thank you, Dr. Yap, for such a comprehensive talk. And have a good day, everyone.
Okay, thank you very much.